Hi, my name is Greg Bolin, and I am chairman and founder of Another Way Recovery Services. And today, very pleased to have with us Dr. Jonathan Hall, our Chief Medical Officer.
Thanks for having me.
Thank you for being here. We wanted to do a follow-on video to answer some, we believe to be important questions that we've received from prospective patients and their loved ones. First question is, okay, you're coming to our house to detox the patient, but just to let you know, the house is quite dysfunctional right now. We wanted to talk about the normalcy of this. We encounter this almost all the time. Our nurses do, which, by the way, on average have about 16 years of detox experience across the entire spectrum of nurses, detox nurses that we use, and a minimum of 2 years of experience. That dysfunction can come from multiple places, but one in particular, and I'd like Dr. Hall to maybe expound on where that dysfunctionality tends to emanate. So can you talk a little bit about where that dysfunctionality might be emanating from and how we might be helping there? Because that certainly seems to be the feedback from customers and clients, or clients who have completed our medical detox process.
Yeah. So substance use disorder is essentially a replacement of normal, healthy relationships with a relationship with a substance, or if it's, say, a gambling addiction or something like that, then a behavior. So it's incredibly normal for anybody who works in this field to encounter social dysfunction. So whether it comes from the substance use or it causes the substance use disorder, family dynamic dysfunction is a hallmark of substance use disorder. And so it's incredibly common for this to be addressed and found by our nurses. Now, every nurse at AWRS has at least 2 years clinical experience working in detoxes. So this is not a new thing for them to be encountering, and we do expect that it's going to be a part of every case that we work on. There's going to be some type of familial, social dysfunction, some disharmony that's going to occur.
Sure.
Yeah. With our nurses and their experience, this is something that they're well accustomed to dealing with, and so this is something that we encounter with every patient that we treat. So we expect a fair amount of dysfunction. Now, Greg, could you tell us a little bit about what we see once a nurse actually gets into that dysfunctional environment? What kind of changes or impacts?
Sure. The first one is that the patient or the prospective patient makes the call, yes, I want the detox. That immediately gives the loved one some relief. Then once that detox nurse arrives, obviously very competent in what he or she is doing, the nurse practitioner is involved, the doctor is involved, the loved one feels a great sense of relief because we are there to treat their loved one. And of course, the patient themselves will feel much better over the coming days as we put you on a taper to smooth out the withdrawal process. It's not all roses, but it does work. And so that would be my call there.
Yeah, and once we start treating active use in a substance use disorder, things are going to improve in terms of the relationships and the function in the home because we're going to be removing that active use component. So people are going to get back to the basics and be able to communicate better. We're just taking away one part of that dysfunction by getting this detox underway and getting active use out of the picture.
That's right. The next question is the idea of detoxing a patient at home versus, say, at a treatment facility. I wanted you, Dr. Hall, to talk about a few things. I'll start off. Number one, our detox process involves a nurse staying with the patient 24/7 for the entire withdrawal management period. That can last 4, 5, 6 days. It just depends on the substance or substances that we're detoxing the patient off of. Our ratio is 1 nurse, 1 patient. Can you talk about what you've seen in the medical field and your experience with, be it medical or even medical as it relates to substance use disorder?
So a one-to-one nurse-to-patient ratio, the only place in medicine that happens is when somebody is undergoing a surgical procedure. They have a nurse assigned to them for the duration of that surgery. So this level of care, this personalization of care is not found anywhere else in medicine. In critical care units, it's a 2 patients to 1 nurse ratio. Even in the ER, it's generally 4 patients to 1 nurse. So even in these high acuity environments, there's just not that same level of attention and concern.
And I will tell you that anecdotal as well as factual data that I have seen over multiple years, the average per patient per day patient to detox nurse ratio at a treatment facility is somewhere around 7 to 1.
The other great thing about having that one-to-one nursing care is that in medicine, where things tend to go wrong is during handoffs, when information is being exchanged about a patient and something isn't communicated correctly. Now with this 1 nurse, 1 patient for an entire detox, we completely eliminate that and remove that opportunity for those errors to exist, which in my opinion, I think has to make our process safer than the type of care a patient would receive in a conventional, traditional treatment facility.
Absolutely, absolutely. Excellent insight. And I guess as our last question that we've received, the continuity of our care. So going through our detox phase 1 process, you obviously, if you desire, would move into phase 2, which is a 3-month intensive counseling and telemedicine process. You will receive 48 counseling sessions over those 3 months, 4 times a week. It's a lot, but we've got to keep you immersed in treatment because you are in a real life setting, and we want to make sure to encounter any relapse triggers or anything that is concerning to you immediately, so that we can hopefully prevent a relapse. And I would like to talk to you, Dr. Hall, like for you to talk to the audience about your perspectives on the medication perspective and keeping up with medication that can help with both alcohol use disorder and opioid use disorder over that period of counseling.
Yeah, so that's really where all the research suggests the rubber meets the road in substance use disorder is getting patients onto maintenance therapy and keeping them on maintenance therapy. So, you know, as addiction is not the opposite of sobriety, but addiction is basically a lack of relationships that a person loves. And so by engaging in these long-term relationships with a counselor, we're really bolstering the chance that we're going to be able to keep that patient in treatment and keep them active with their maintenance therapies. And so I think ultimately giving them a better chance at being successful in their recovery. So I think all in all, the continuity, be it from the detox nursing to the counseling aspect, I think really increases the chance that patients are going to be successful in recovery.
Absolutely. And the formula is quite similar, as simple. It's keeping the patient in a real life setting. The patient will invariably encounter relapse triggers. And if we can address those relapse triggers with the patient, or even lessen the impact of a relapse should it occur, then the outcome should be, and what we are finding it to be, is higher self-confidence, which typically tends to breed higher self-discipline, which over the long run should breed long-term sobriety.
And we know that when somebody takes control of one domain of their life, it makes it so much more likely that they're going to be able to get control over another domain of their life. And so if we think about that, you know, success breeds success. And by helping people, giving them the best opportunity for success, we think that we're priming them for the best chance of success in life, not just with recovery, but that's obviously what our first goal is.
Absolutely.
Is to help them in the recovery.
100%.
Yeah.
Thank you so much, Dr. Hall, for your time.
Thank you, Greg.
Thank you.